pleasure to be here. Glad I could make it across the pond and tell you a little bit about some work we're doing at the end at the Center for Smell and Taste, University of Florida, but also about a broader question of smell testing and incorporating it into healthcare, including in the context of this conference that's going to be happening starting tomorrow in Philadelphia, but also online. So if anyone's interested, there's a QR code. I'll put it up again at the end. You're welcome to do it. So this is a conference that's going to involve patients, clinicians, scientists, regulatory personnel from a variety of organizations, government, focused on what are the barriers to and potential paths forward to incorporating smell and taste testing in regular health care. It'll be US focused in a lot of ways, some of our unique joys, things like insurance and all of that, but it very well may be of interest to any of you, and it's inexpensive. You can attend it virtually on Monday and Tuesday. So this is what I'm going to tell you about. I want to, a couple of disclaimers. First of all, one, I'll have a US perspective, because as some of you may have already determined, I am not British. That's what I will know, but hopefully a lot of it will generalize well here. And secondly, while I'll be talking primarily, I'll be mentioning smell testing, because that's really where it's more advanced and such. Most of this is relevant to both smell and taste testing, which collectively I would refer to as chemosensory testing. Keep that in mind as well. So what do I mean by chemosensory testing? What do I mean by making a regular part of healthcare? What are benefits, patients, to providers, to others, barriers to implementation, and next steps? So types of smell testing. So chemosensory testing is generally going to be tests that are requiring some response from the individual about whether you can detect something, what you're detecting, how much you are detecting, these types of things. These are grouped into what we determine psychophysical tests, in that they are constructed to somehow quantify that response, but it still does rely on the individual responding. We have very little the way of technology yet to completely objectively measure how well smell or taste is working. So there are a variety of different types of tests. In the United States, the most commonly used one in clinical settings are these odor identification tests, particularly one that's known as the UPSIT, the University of Pennsylvania Smell Identification Test, which is over here on the left-hand side. It is 40 questions, scratch and sniff, with specific odorants and a choice of 4 options to select from. Is this lemon, onion, rubber tire, whiskey, or some variations of that? But there are other ones, components of the sniff and sticks test that Carl tends to use more often, also do with odor identification. These tests like this are good at assessing quantitative olfactory ability. So what I mean by that is normosmia, normal sense of smell, hyposmia, reduced sense of smell, or anosmia, no functional sense of smell. They aren't good at assessing phantosmia, phantom smells, or parosmia, which are distorted smells, where something smells wrong compared to what it should be. These tests have been used for years. They are strongly validated. They're really robust. They have excellent reliability. So lots of positive there. They have disadvantages in that they require high cognitive load. Not only do you have to be able to smell, actually have the mechanics to be able to smell that odorant in order to respond to it, you have to be able to remember what that particular smell refers to in your experience. You have to be able to pair that with a word or a picture. You have to be able to say it or mark it down, relate it to the provider that's giving you this test. These are all things that may be confounded with your ability to smell in and of itself. If someone has neurodegenerative disease, Alzheimer's disease, and is having a compromised sense of smell as well, they may not be able to recognize an odorant because they can't smell it, or they may not be able to tell you about it and pick the right one because they have some cognitive decline. So this is one of the big challenges with this kind of thing. They're also impacted by experience, including cultural differences in age. They don't work really well for kids under the age of 10, which might be relevant especially in the context of congenital anosmia, because it's just harder to do. And sometimes children have not experienced all the different odors that this might test. And it can also select, sometimes these tests have odors that you just never would have encountered in your life. Early versions of this test, one of the odors was root beer, which works really poorly in Europe because people will say, what in the world is that? I have never heard it. So there are limitations to these. There are other versions that are used quite commonly, are called odor detection threshold tests. So these tests are to measure how sensitive someone is to one particular odor. So again, good at assessing this quantitative olfactory ability, not for phantosmia or parosmia. Also strongly validated, really reliable. So, and what they will do, and this is an example on the left-hand side of the sniff and sticks version of the odor detection threshold test. This is going to quantify smell function across a range of concentrations. What is the lowest concentration of a single odor that you can smell? That's great. It really lends itself to repeated testing over time so you can measure how someone's sense of smell might have changed. This can be confounded by something that's called a specific anosmia to the test odorant. So there are some chemicals that some individuals cannot detect. I'm completely incapable of smelling the compound androstenone, which is a pig pheromone that taints pork and sometimes. A lot of other people, my wife can smell it well, my kids cannot. There's a genetic difference. I don't have the odorant receptor for that. But in general, my sense of smell is perfectly normal. But having these single types of specific anosmias is fairly common. They can vary, so if someone is testing one for which you have a specific anosmia, you could have a 0 score on the test, but still have a generally normal sense of smell. So that's something to be careful about. These also require a test administrator. In this particular style of test, in most cases, someone to actually work with you. And that, in a clinical setting, that takes time. You need to have a nurse or a technician or a physician that is going to be working with the patient in order to give the test, as opposed to the odor identification test, which can be largely self-administered. So that is a time and cost disadvantage. I'm not mentioning discrimination tests. Can you tell the difference between two related odorants? Those are also components that generally aren't used on their own very much. There are also rapid tests of various types. There are ones that are odor identification tests. There are ones that are threshold tests. The top left there is something that is I'm a co-inventor of, called the Adaptive Olfactory Measure of Threshold, or the Aroma T test, which is a very rapid odor detection threshold test. The bottom is one called Sentinel that was developed at the Monell Chemical Senses Center that is a very single odorant screening test. Then they are, once again, good at assessing olfactory ability. They are typically self-administered, which is a big advantage in a lot of settings. They're easier to use outside the clinic. People can use them in their homes, can use them at workplaces, do it in field studies. These are all helpful. They are significantly less expensive, which especially in the US is a major factor because health insurance does not cover olfactory testing in almost all cases, or taste testing for that matter as well. So that cost is either fully borne by the provider or by the patient, not covered by insurance. So having something that's significantly less expensive can be a big advantage. They're less statistically robust than these longer tests. They ask you fewer questions, so it is harder to get very precise answers, but they are still useful. They also, because these are more newly developed, they haven't been validated in as many different populations and to the extent of some of the other tests I showed you. Just to mention, there are taste tests as well. Briefly put it there, on the right-hand side is an example of the types of taste strips. These are pieces of paper or matrix that are embedded with sugar, salt, acid, bitter compound, or an umami compound, glutamate, and at different concentrations, and you could use it to, can you taste these specific tastes? On the left, this is one of the truly objective variants called an electrogustometer, and basically by measuring changes in electrical activity as is put on the tongue when you're tasting things, it can give you an approximation of whether taste function is working. It's a little crude, but it is probably the most objective one. So we have all these different types of options, very few of which are used in regular healthcare. You go to your family doctor, your general practitioner for your annual wellness checkup, you don't, in most cases, get a smell or a taste test. That's not, you get blood pressure, you get your cholesterol measured, you get whatever, creatine levels, all these types of things, reflexes. You don't get chemosensory testing. You might even get vision and hearing testing as part of that. You don't get chemosensory testing. There are barriers to that, but there are examples from other sensory systems where we have incorporated that successfully into healthcare quite well. Hearing is one example, certainly in the US, and I think here as well, where that's done at several different stages. There's childhood screening immediately after birth with otoacoustic emissions. And then as children entering school, they're screened as well. And this happens to almost all American children. The reason to do this early on is because hearing is so important for language development and for learning in school, that identifying a child who has a hearing impairment or is deaf early on allows for early intervention that can help them to develop language in a normal way, whether it's getting sign language, cochlear implants, or whatnot. There's also ongoing adult screening that relies more on the patient doing it. These are recommended every 3 years for healthy adults. I would say because, though, they aren't part of the regular wellness visit with the general practitioner, most adults do it infrequently. They do it when they have a problem. I've got tinnitus. I can't hear people in a crowded room well or whatnot. Then they go, and this is done through specialists with otologists, type of otolaryngologists, that will give more sophisticated hearing tests. So can we use these types of things as a model for getting chemosensory testing into regular health care? Childhood screening, there are a couple things. As Deb's just mentioned to you, congenital smell dysfunction is rare. It's real, it's impactful, but it's not common. So there's always going to be that cost-benefit analysis that will be whether you can do it. It's also not nearly as quick as doing a quick hearing test on a newborn or even a childhood test, because olfactory testing has to be optimized for children. This is an example of known as a smell wheel. It's something that requires an administrator to work with the child to do sort of a smell odor identification. They scratch and sniff. It's a little more involved, takes a little more time to do so, but it is a valid test for younger children. Adult screening, the ideal way would be to have some sort of assessment, even if it's a simple screening test, rapid test like I showed you, into annual wellness visit, where you could identify the developing smell disorders, increased loss. Ideally, we'd also be able to develop tests for phantasmia and parosmia as well. We don't have those at the moment. But could we make this something that you do every year? At the moment, that is not the case. Currently, smell testing is really typically only conducted by specialists, otolaryngologists, most commonly. And once again, usually only happens when someone is already self-identified a problem and is looking to get diagnosed and potentially treated. So how would patients benefit from having regular chemosensory testing in healthcare. So for one thing, healthcare providers and society more broadly may become more aware of chemosensory disorders and their impact on patients. This can help normalize chemosensory disorders as a true health issue. I'm sure most of you have encountered this over your journey through being diagnosed, being assessed, of having healthcare providers who are dismissive or ignorant of the problem, or ignorant of how to move forward to next steps, advice to give, potential treatments, all of these types of things. If testing is a regular part of healthcare, they're going to be learning about it. They're going to be learning as they go through their training and such, and becoming better providers, better carers for their patients. Early identification of these disorders in children can hasten therapeutic interventions, depending on what there is. If someone has a deviated septum or has something else that's structural that could be repaired early, that might be allow one to overcome that limitation. But it also is going to help teach children lifelong coping strategies, ways to change the way they relate to food, the way they communicate with other people about their condition, as Deb was nicely describing. These types of things to prepare, if this is going to be a lifelong challenge, prepare those children for this. Longitudinal assessment of function, by that I mean getting tested every year and tracking changes in your test results every year, can help identify not only changes in smell itself, which is important, but also reveal associated health problems. If, example I was giving last night, if you have a 20-year-old come in and they've had their smell tested last year and was perfectly fine, they have their smell tested this year and they can't smell anything, they haven't really noticed this, and their doctor saying, well, would everything change? Did you just have a bad cold? Oh, no. Well, I was riding my bike the other day and I fell off and hit my head, but so what? Well, maybe they have a traumatic brain injury that needs to be assessed. You have a 65-year-old come in and they have a degradation in their olfactory ability from the previous year, and they're also complaining about being constipated. This constellation of two symptoms is really indicative of a potential Parkinson's disease early stage diagnosis. Not absolutely diagnostic, but enough that it would be say, well, we should refer you to a neurologist to have a workup on this and see if this is a thing. So it's a sentinel warning of other type of health problems. This is important. There's also, as you know, lack of appreciation, the public, healthcare professionals, regulatory agencies, and all these times about the prevalence of chemosensory disorders, the importance of chemosensory health. The idea about prevalence has changed a lot in the last couple of years with COVID-19. People are more aware. They're still not aware that it was common before that. The millions of people, really, it's 12 to 15% of individuals over 40 years of age have a clinically significant chemosensory disorder. That's pre-COVID numbers. Adding COVID on top of that, even greater. This is a major problem, but that lack of understanding of that is a big barrier. And then this is a problem in the US. It is luckily not an issue here with Fifth Sense. There really is an absence of mature patient advocacy organizations that can lobby legislators, regulatory agencies, etc., to support chemosensory testing, to support insurance coverage of this in healthcare. So Fifth Sense is really a model for us in many other countries about how to grow this type of public education realm. To be broadly adopted by healthcare providers, these tests have to be inexpensive. They have to be quick to administer. You only have a few minutes with your doctor. You can't be taking 50 minutes, they're not to do a chemosensory test on an initial screening. They're just not going to have the time to work that in. So having a quick test is important. It has to be reliable and validated. If you have a result that changes, your doctor has to know that they can be confident to send you to a referral or to do additional testing. They don't want to be wasting anyone's time. And then in the US particularly, there's a lack of health insurance coverage for this testing. There has to be a mechanism to support the time and cost of this testing. So these are all challenges. And then finally, we have to have a better understanding of normal chemosensory variation. And this is a problem that my own group is working on at the moment, is just like if you were to have your blood pressure taken today, if you were to take it in the morning and to take it in the evening, it's not going to be absolutely identical. But we know through years and years of experience that having your diastolic off by 1 point this way or that is not clinically significant. Still, there's a normal range, there's an abnormal range. True for cholesterol, true for creatine, true for all these other biomarkers of your health. We don't really have that, at least not fine-grained enough, for smell and taste function. We need to have that. So how much does normal smell function, taste function vary within different time periods? Morning versus night, daily, monthly, yearly. How about people with chemosensory disorders? If you have hyposmia, do you have the exact same level of ability to smell every day? Or does it wax and wane over time? These are important things to know so that when we're assessing someone's function, we know what is just a little bit of change versus a true therapeutic change or a true disease change. Similar in context, Parkinson's disease, other types of things. And then does smell function vary with normal physiological changes? We hear anecdotes all the time about women gets pregnant, all of a sudden their sense of smell changes. They're much more sensitive to certain odors than not. This is mostly anecdotal evidence. There's very little science on this. So what are the types of changes that happen over normal physiologic variation for individuals? Once we know those types of things, then we can more reliably use chemosensory testing in a clinical to really understand how someone's chemosensory health is changing. So we actually have a new National Institutes of Health grant to investigate exactly this, to establish baselines that can be used by the broader community to refer as a reference point for chemosensory testing. So what are our next steps? One, stakeholders, that includes all of you, have to work together to understand these barriers and to develop strategies to address them. So we have to convince medical education groups, those groups that determine what new doctors and nurses and everything are going to learn about human health. They have to make sure that they emphasize chemosensory function and dysfunction in the training of those medical professionals. That's something that's done. I'm in a university that has one of the largest smell and taste centers in the world, and our medical school does not have a single hour of lecture on smell or taste. Yeah, it's a little frustrating. And that's not uncommon because it's not something that the licensing boards and everything, they test on. If you go into a specialty that is relevant, otolaryngology, you will get some instruction on that at that later stage, but a general practitioner gets nothing. We also need to educate public regulators, legislators also on the importance of chemosensory testing, including covering costs, because they're the ones that control the funds that can help to facilitate incorporating this. Scientists and clinicians, we have to continue to develop chemosensory tests that minimize the barriers to use in clinical settings, field settings. By field, I mean at a health fair or people's homes or some outside of the clinic. Once again, it has to be inexpensive, quick to administer, preferably self-administered, so you don't need someone else doing it for you. You can just do it with an app or whatever. Culturally agnostic, has to work for, or at least have variants that will work for anyone, no matter what their cultural experience. Minimize those confounders of things that might be a problem of having to remember the name of something or whatnot. Needs to be quantitative so we can follow trends across the years and compare from test to test. And they have to, of course, be statistically robust so that that provider can confidently act on the results. That may be, okay, your quick screening tells me this. I know I now need to give you a full battery of screens. Or now I can say I'm going to refer you to this specialist, this neurologist, the otolaryngologist, or whatnot.